I want to give the audience an opportunity for questions. So, all of our speakers have just opened up areas of discussion that probably could go on for a couple hours. So there's really just one question I want to ask of Dr. Bell, and then open it up to all of you to see what your questions are. And that really is, as you were giving your presentation and talking about both emerging diseases but also re-emerging diseases, I'm wondering if you see that there's a trend. Is there a change, let's say in 50 years, that we're seeing more of this? Because I don't have any personal perspective on whether that's the case. But I wonder if you can speak to trends and if there's something we can do to look further down the road, because it seems like Ebola virus emerged in a big way, and then we're like, well, where are the tests? Right? What are the better practices we have? But we've known about Ebola for a very long time, and you pointed out the first Zika virus was isolated in the late 40s. So what do we need to do now to look down the road on some other viruses that may be with us in a bigger way later?
Yeah, thanks. I think that there are some kind of trends that promote the sort of emergence and reemergence of infectious diseases that have intensified over the last several decades. One is just global travel and trade. We really do live in a completely globalized world these days, much more so than, say, 50 years ago. And that sort of ability of, someone to hop on an airplane and be halfway across the world in less than a day does promote spread of infectious diseases. Another thing I think is this sort of growth of these large urban megacities. And this, I think, was an issue, for example, with Ebola, where, we had seen Ebola existing and spreading in relatively small rural communities. And once it found its way into a large urban center, the transmission dynamics were such that the effect was amplified enormously. The same, I think, can be said for the way we saw chikungunya virus spread and also Zika virus spreading now, that this combination of the ease of microbes in people to spread around the world and then these large concentrations of people in urban centers promote this sort of the reemergence of infectious diseases that we're aware of, and also make for kind of incubators for new emerging infectious diseases. So from the diagnostics perspective, I think, your point is obviously a really good one, that there's kind of two sides to this. One is where there are agents that we know about. We have maybe a diagnostic test that, we have at the CDC that we can deploy in, sort of one-offs that work okay but have their definite problems and are sort of, as I say, okay from a research perspective. So for Zika, for example, I think there was something like 14 case reports of Zika virus infection before this sort of spread through the Americas emerged. So the needs for diagnostic are totally different when you're in the midst of a huge outbreak like we are now, and with a new potential manifestation of microcephaly, which means that you got to be able to screen, which is not something that we ever thought about. And so I think that, and some similar points could be made for Ebola. And then, of course, there's the other side of this, which is being able to rapidly identify new infections. So this is all, I think, an argument for the kind of improved ability to detect that we've been talking about, strengthening both globally with the global health security agenda and domestically with our work with the state and local health departments. So people thinking about this and having the tools to be able to detect quickly. And then I think that, there may be some interesting ideas and innovations in terms of how we might be able to have platforms that are more flexible and that could be easily transferred from one not very well understood pathogen that suddenly becomes something we have to understand better. And so this, I think, is an important area to consider a little bit further because, this business of having to scale up a diagnostic, which is not really meant for the purpose that we're having to apply it to, is oftentimes a really important limiting factor in terms of sort of understanding the scope of and stopping some of these large outbreaks.
We'll throw it over to the audience, Mark. You want to just identify yourself? Please?
Sure, Mark McCarty with Medical Device Daily. It sounds so in some instances from what some of you have said that coverage is sometimes the issue, sometimes the reimbursement level is the issue, but stepping back up a couple of thousand feet, you've got a number of payers that you have to grapple with. CMS doesn't do much of diagnostics. They offload that to Medicare and Medicaid contractors, and then you've got a couple of handfuls of private payers you have to go to. What's the overall communication strategy with payers at this point for things of this nature? Is there one? Who's going to be the voice? CDC, FDA? I mean, is there an overarching strategy here, or is it still sort of a tower gap?
Well, there's probably a number of things I could say from the perspective of the trade association representing these test manufacturers. We have an ongoing work in a number of areas around better diagnostics reimbursement, and I would note that CMS is in the middle of actually implementing substantial Medicare payment reform. Sure, it's still a year out, but if you think about it historically, it's the first major change to diagnostics payment, at least on the clinical laboratory fee schedule, that's taken place since the 80s. So I wouldn't underestimate how significant it is. Again, kind of in historical context, and just as one bullet on that, this is the implementation of statute passed in 2014 that directs CMS to start paying for diagnostic tests on basically an equivalent basis to what private payers are paying. But that only covers tests that are paid on the fee schedule. It does not address issues around bundled payment and how tests are taken up and essentially paid for in accountable care organization arrangements and that sort of thing. But I think I would turn to ask Dr. Hansen maybe to address a little bit further your question in terms of what the challenges are around reimbursement in a private system that's trying to drive better utilization and have the right tests on hand for the right patient at the right time.
Yeah, and I didn't even get to the whole issue of diagnostic-related groups and bundled payments. In some ways, for our most complicated inpatients, we get reimbursed a certain amount for a liver transplant. And in some ways, there may be a disincentive to call an extra consultation, order additional tests to drive up the cost. And I think the message from our point of view is we need these outcome studies to prove that diagnostics really can make our clinical practice more cost effective, that they save money in the long run and that they should be utilized. In terms of reimbursement, I'm most up to date with the work that's being done at CMS, which I think will be very important as we go forward.
Yeah.
Yeah, I think it's more for infectious diseases that have been problematic as hospital-acquired infections, for instance. Studies around detecting MRSA quickly and how that improves outcomes for patients. Does it make sense, these rapid diagnostic tests from the bloodstream, spending couple $100 on that test, does that really translate or make a difference? If we get the medicine started sooner, does that improve outcomes for patients? Do they really get out of the hospital sooner? Do they get out of the ICU sooner? And so I think for our multi-drug resistant hospital-associated infections, the outcome studies are desperately needed.
Carol, you wanted to add in something?
Yeah, along those lines, I would say that I know that the public partnered with Cephed on their rapid testing for MRSA and also some of their others. So I really do think that it's probably a good time to revisit their price structure because they do have a test that works, and if we made it affordable, if we made it appropriate and accessible to all, it could probably answer a lot of questions, and it could become a more reasonable topic to discuss with CMS on reimbursement. The other thing that has been addressed in the past, just recently on diagnostics, is the biggest driver for overusing antibiotics is the fact that physicians don't test. And I know today there is a test that is available in Canada that can answer many of our questions. And it can test for a virus, and it could test to see if you have bacteria. So I can envision this in the hands of a mother like me, who instead of waiting for a prescription that won't work, has now tested my son with this test and it says it's a virus. Well, then I'll call the doctor and I'll say, what can we give my son that will help him feel better? If it's a bacteria, the box will say, get an appointment immediately with your physician, and if you can't, get in the emergency room. This is what Canada has available. I can't imagine why we can't work with them and partner with them to have that in our hands very soon.
And I'll just make one very quick point about the nature of diagnostics. That may seem self-evident, but I think it's really important as you think through all of these things. You think through, uptake of new diagnostics, Kim's point about clinical utility studies, about leveraging current diagnostics, about the flow of diagnostics information through a system. Diagnostic tests produce information. So when we talk about tests, we're almost always talking about information. We're talking about the quality of the information that's generated in the first place. We're talking about who uses it, when is that information needed, how does it affect decision making, what's the delta in downstream outcomes and quality of care that result from having this information available earlier on. And so if you think about the clinical utility challenges that Dr. Hansen in particular was talking about, it's all about the impact of information downstream and what does it cost to generate that information up front, and what kind of difference does it make further down the healthcare continuum. And I think, as a general matter, we're all persuaded that the cost of diagnostics in virtually every circumstance is far outweighed by the benefit downstream in changing decision-making and, resulting in better care. But because of that complexity of series of steps and also some systemic challenges in making sure that information gets uptake in the right places, the actual health economic analysis is complex. It's far more complex than looking at the direct impact of a therapeutic, whether that therapeutic is a drug or it's a medical device that's, the direct impact on the body. And so those are some of the challenges that we're confronting, and it's kind of an ongoing area of challenge and exploration. I feel like we're making progress, but I just make that broad point because I think it's very helpful as you think about these problems. So yeah, Tad.
Ted Lazarus, QIAGEN. Indy, I just wanted to comment to expand on what you just brought up. When I spoke here a little while ago, I brought up the point, imagine if when you designed a new pharmaceutical agent, in addition to that, you had to build a box for it, you had to design software to run the box, and bioinformatics to do an interpretation. And that's what diagnostics is. And now, on top of that, is this big question mark about outcome studies. So and I think all of us in the industry, especially those of us who are chief medical officers, want to have that kind of evidence and demand it. But as we undervalue the reimbursement for diagnostics, and what's coming up is only going to be really just a little bit of a course correction, not much. I think the most tangible point is to say, or the take-home point, let's all get behind the outcome studies, but let's make sure that they are third-party, they are participatory between private and public in terms of funding. What we haven't done in my 20 years in this industry is finally put a stake in the ground and say, yes, indeed, for everything that's new and novel that comes out of diagnostics, we must have these outcome studies, and here's how we're going to fund it. And that hasn't happened in my 2 decades of working.
Thanks for those comments. We need another question.
So, Natasha Lee, Senator Brown's office. In regards to, I guess, the discussion that Stephen brought up with BioRed, can you talk a little bit more about any future diagnostics that we can expect, especially for those slow-growing microorganisms like tuberculosis and others, that it's a little bit harder when you have those multi-drug resistant forms to actually first diagnose what it is, and second, identify which strain of resistance it is. And then second question, kind of leading in from the conversation of the National Action Plan and looking at additional attention on stewardship. I think that the accompanying piece has to be the diagnostics, because you can't have proper stewardship if you don't know what it is.
Okay, well, maybe Steve, you want to take that first question?
So with regards to your question about how can we get results faster, this is actually an active area that we're working on, and one of the really best answers is miniaturization. So many fields have benefited from miniaturization. Sequencing, which you've all heard of course, is largely based on our ability to miniaturize. So we are, in fact, looking at ways to miniaturize the traditional culture concept into something that would allow slow-growing organisms to be tested faster. And that's something I'd like to speak to some of our other panelists about when time permits. This is a relatively new idea, but it's certainly just one of the ideas people are working on to make the growth process go faster, which you correctly identify as a big challenge with regards to not just slow-growing organisms, but all organisms. So I think there is some hope in that area. I have to tell you that 15 years ago, the idea of making culture go faster was really not on the table for a lot of people. It's a relatively new idea that's emerged in the last few years, but I think we can see some progress there.
And I don't know, Dr. Bell, do you want to take the lead on the stewardship question?
Yes, you're absolutely right that a diagnostic that can distinguish viruses from bacteria or otherwise guide treatment choices is really a very important component of stewardship. But I will say I think there are some other things that we also need that are probably just as important. One to highlight is that drawing a parallel with some of the successes that we've seen in reducing healthcare-associated infections like central line-associated bloodstream infections, one pivotal part of that is having a feedback loop so that you're able to measure what your rate is. A hospital knows what their rate is and can use the data. The state knows what the rate is, and they can benchmark they can identify areas in the state where there are problems that they can focus their interventions on. And nationally, we have comparable rates from each state so that states can compare and they can track their progress over time. So in the area of stewardship, we really need to be able to measure antibiotic use in a similar kind of way so that when a hospital can look and see how they're doing in terms of use and stewardship, and we're able to apply those same principles that the states can see. What are the differences in prescribing practices among facilities, and we're able to benchmark nationally. So we're actually in the process of trying to develop at least the first attempt at a metric that could be applied, but we really need the National Healthcare Safety Network module on antibiotic use, which will electronically capture pharmacy information and allow facilities to measure antibiotic use in their facilities. We really need to have that implemented broadly across healthcare, and that's certainly one of the things that we're working towards with the action plan. We'll need the cooperation of the vendors, the electronic medical record vendors, in order to scale this up the way it needs to be scaled up.
Just to add on to that as well, I think that people need to know we're finding that dental offices are really contributing to the overuse of antibiotics. So any of these inventions, we really need to make sure that we're tied into dental. I know that Kaiser did a very big study to look at what did their use look like, and more than often, the dentists were, I know my dentist has an antibiotic waiting for me before I even get there. He doesn't even know if I need it. So that's a huge focus. I know that we know of someone who actually contracted C. diff and from their dental office and passed away. So we've got to put a huge focus in dental offices as well.
Well, we haven't run out of things to say, but we have run out of time to say them in. I thank you all for staying to the end. I hope you've come away with a somewhat better appreciation for the pivotal and critical role of diagnostics. It's also a tremendously complex area, whether it's in terms of technology or utilization or policy, and I encourage you to continue following up with us and other stakeholders and learn more about all the things we're doing to advance the role of diagnostics in healthcare. And I want to please thank me in joining all of our speakers for their great presentations.
Thanks for coming.